So I think that the most important thing is to have a multidisciplinary team in your hospital. For the locally advanced disease is really the key point of the treatment. It is important to have a multidisciplinary team which is composed at least by the medical oncologist, the surgeon, and the radiotherapist. And it is also important to have, if it is possible, the radiologist and also the nuclear medicine physician, because the key point of the right treatment for locally advanced stage 3 non-small cell lung cancer is to define exactly the right staging. And this is the reason why we include in our cancer center also the radiologist and the nuclear medicine team, because you can exactly define what is the volume of the tumor, what is the nodal involvement in the mediastinum. And this is the key point to decide if to go with surgery or to go with chemoradiation or with chemo alone or with radiation alone. So I think that in 2018 it is mandatory to discuss in a multidisciplinary team every stage 3 non-small cell lung cancer. And it is also important that the patients are aware that the right treatment can be done only in centers where a multidisciplinary team is present. And if the multidisciplinary team is not present in the same cancer center or in the same hospital, it is important that every medical oncologist have some referral points in other hospitals for the surgery and the radiation oncology. Because you can decide case by case a totally different approach with the multidisciplinary team. And sometimes in my hospital we are fighting every time if go with the chemoradiation or go with surgery, because sometimes are really tricky decisions.
In locally advanced non-small cell lung cancer, only some patients can benefit from surgery. We face again here the problem of heterogeneity of this disease defining or being defined by locally advanced. Some of these patients can simply not benefit from surgery. I give you an example. When you have positive supraclavicular lymph node, you cannot perform surgery on the lung and resect these lymph nodes. It doesn't make sense biologically and it's not anatomically feasible. So some patients can simply not benefit from surgery. But some selected patients can be operated, can be surgical candidates, right? In that setting of surgical candidate, in this very precise subgroup of resectable stage 3, we also encompass here the patients with nodal involvement, but called N2, on the same side of the tumor, right, in the same half body than the tumor. These patients must be highly selected, and even here there is a controversy. There have been 2 randomized trials trying to address the role of surgery versus no surgery when you replace surgery by radiotherapy, right? And both of them are not able to really show that one modality is better than the other one. Or if you want to make a long story short, that you need to perform surgery because you could do radiotherapy, which is considered to be a little bit less dangerous in that setting. One of these 2 trials, however, the one from the American, it's called an intergroup trial, was showing that if you don't do a big surgery like pneumonectomy, if you just take a lobe out, a lobectomy, in these patients, maybe surgery is a bit more efficient than radiotherapy. But it's an unplanned retrospective analysis, right? So it doesn't close the debate. It depends really on the country, the region, and the local politics you live in. In my country, for example, in Switzerland, we are very surgical. So we have been performing for stage 3 with an N2 disease. We've been performing a lot of surgery in resectable patients. But when I was in the US, for example, this patient had radiotherapy and chemo and no surgery. So it's really kind of geographically defined. We all have our own standards of care. I think at the time being, nothing is right or nothing is wrong. In the ESMO guidelines, we have led the 2 options. You can choose between surgery or radiotherapy in stage 3 disease. With chemo, always with chemo.
So the optimal treatment must be decided in the multidisciplinary team, because you have, if you decide that the patient is operable, and this is done with the surgeon, maybe you have to answer the question if to go with chemotherapy before or go with an adjuvant treatment after. So there is, in the last 15 years, there are several studies on the neoadjuvant setting and also the neoadjuvant with chemotherapy or with chemoradiation therapy. However, all the studies, all the trials are small, and sometimes when they started, they were with old techniques. And so the results at the end are quite controversial, and still now, in 2019, we have no a clear answer which is the best sequence for treat this kind of patients. So what we need is a balance between the toxicities and the aim why we do something. For example, for the surgeon can be important to reduce the tumor volume, and because it is easier later to operate the patients. In some cases, this is important also for example, for the if you want to reduce very quickly the tumor, maybe also chemoradiotherapy can be an option. But we have also to think that chemoradiation as a neoadjuvant treatment is a quite a controversial disease, because it is true that we have more complete responses when we operate the patients, but all the studies, all the trials were negative to prove a benefit in terms of overall survival and progression-free survival. So if you have the goal to reduce the tumor and to render easier for the surgeon the operation, you can decide which is the most powerful regimen. In other cases, for example, there are some stage 3 tumors that potentially are operable from the beginning. And in the multidisciplinary team, you can decide to go with the operation immediately, and then maybe to go with the adjuvant therapy in a second part of the story of the patient. What we know, and it is important, is that we have, in both cases, in the neoadjuvant setting and in the adjuvant setting, we have a reduction of the risk of death, which is very similar. There is a reduction of risk of death of about 5% if we go in the neoadjuvant and if we go in the adjuvant. What it is important is that sometimes it is better to go with the neoadjuvant chemotherapy before the surgery, because patients are in better conditions than after the surgery, and sometimes the chemotherapy is more tolerable than after the surgery. So again, it is a balance between the toxicities, the conditions of the patients, and what is the goal that you want to achieve with the treatment that you are going to do. The chemotherapy, there are several studies of neoadjuvant chemotherapy, and the overall response rate with chemotherapy ranges between 25 and 40% with all the regimens. So there is not a favorable regimens. But you must be also aware that in not only all the cases you are able to reduce the tumor and then go with the operation. So you must be very careful to go with the neoadjuvant because you can miss also the chance to operate the patient in a second part of the life. So it is always a balance between the medical oncologist and the surgeon, which is the right moment and the right treatment to be done for the patient in that moment.